Thanks for joining us this morning. My name is Scott Keefer. I'm with Blue Cross Blue Shield of Minnesota, and I see a lot of familiar faces who have been here before, but I'm going to start with the typical admonition, which is to say this is an election year. If you're here to talk politics, this is a university and it's Minneapolis, not St. Paul. You're probably in the wrong place. For those who have been here before, you know that we set out to talk about the policy implications of healthcare reform. And today we're very excited, thanks to Professor Jacobs and the partnership that he and I have developed over the last 3 years. I think today we're probably endeavoring on the next course of healthcare reform. And that is something that's very important to the state of Minnesota and how we modernize our Minnesota Care program. And we hear from our outside all-star panel. Deb Bachrach will be joining us in a moment to hear about the exciting innovations that are happening in the laboratories that are the states in these United States across the country. And I'm very pleased that we have Commissioner Jessen, some former Medicaid veterans, Andy Allison and Brett Davis, respectively from Arkansas, Wisconsin. We can draw on what they're experiencing, as well as listening to Deb Bachrach and her work across the state, and Representative Matt Dean as well here to offer his perspective. Before we get started, to set the stage, as I said, we've charted this path in the past where we've talked about the policy implications for the state of Minnesota, have had terrific participation from the audience. I think when we think about what unites us all, we have to remember first and foremost that health coverage is about people. And I think if we start there, we recognize the successes of the state of Minnesota in reducing our uninsured rate by 40%, but we think about how much better we can do. We think about the path that lies ahead, the challenges that we'll continue to face in 2015 on an operational basis, but how we're going to pull together as a state, as a community, and move forward. So as you reflect on what the speakers are saying today and you think about that this is about people, I want you to think about a few unresolved policy issues and how we're going to move forward here in the state of Minnesota. The first and foremost is that at the heart of these people, what we want to do is improve their health care, improve their health situation, and keep them well. Secondly, something that's really important in setting out the basic health plan at the national level and creating that as an option under the Affordable Care Act, how do we best manage the transition of people moving from public coverage to private coverage? As my first boss in the U.S. Congress used to always remind me, nobody aspires to be on Medicaid. Nobody aspires to be in PMAP. So whether you're a Democrat and you talk about income inequality, whether you're a Republican and you talk about social mobility, we're really talking about the same issue, and that is how we help people pull themselves up, help themselves, and improve their situation and move forward economically. The third thing I'd like you to think about is we have to do that in a fiscally sustainable way. Now's the time for this conversation. I know in talking to Representative Dean beforehand and Commissioner Jessen, the last thing we want to be doing is having this discussion the next time we're staring at a budget deficit. We just hope that it's not $5 billion, heaven forbid. With that, I think the final thing that I would say is, how are we going to use the public programs platform as a vehicle for delivery system reform? How are we going to use that to change and realign payment, change and realign behavior, and first and foremost, engage those individuals that this is about from the get-go? So with that, I'll take a step back, and I'm very pleased to welcome Deb Bachrach to the microphone.
Thank you, Scott, and thank all of you for coming this morning. It's a pleasure to be here, and I get to talk to you about my favorite topic, the Medicaid expansion. So let's just step back and remind ourselves how we got here. It's June 2012, and the United States Supreme Court decides that the decision to expand Medicaid belongs to the states. It wasn't Congress's to make, it's the states to make. And that decision is whether or not to expand Medicaid to 138% of the federal poverty level for all adults. In our language, 138%, that's about $16,000 a year for a single individual. Remember, at this point in time, virtually, it's a handful of states provide Medicaid to childless adults, adults that don't have a child living with them who are under 65. So even if they're making 5,000, 7,000, very, very, very few states. I think it was less than 5. On average, states only covered parents to 61% of the federal poverty level. So the decision has enormous implications. And remember, also, the federal government says, we will pay for the full cost of the expansion for 3 years, and will never pay less than 90%. Confronted with that option, a significant number, but a minority of states immediately said, it's a moral and economic imperative. We're expanding. Some of those states did a breakdown of the economics and confirmed their gut instinct. The economics worked, and they were moving ahead. But by the end of 2012, the lens shifted, and states realized that they were now in the driver's seat. So it wasn't expand or don't expand, it was expand how. And that's what I want to talk about today, the how. As more states came to the decision to expand, how became increasingly important. So this is today's map. The yellow are states that have decided to expand, and we're going to talk more about those. The gray have not expanded, and I use the word expanded under the Affordable Care Act. There are different ways to expand, and I know when we talk about Wisconsin, you'll hear one way, but I'm talking about expanding under the Affordable Care Act. All adults covered by Medicaid up to 138% of the federal poverty level. Pennsylvania and Indiana have waivers pending with the federal government that say, yes, we want to expand, but we want our own set of bells and whistles, and I'll talk some about that. Then a number of the other states that are in gray, I would say it's still in play to some degree. Montana, Tennessee, maybe Missouri, Maine, it's still in play. So let's look at what in play means. So I've divided the next two slides into two buckets. The first I call the delivery models, and the second I label the coverage models. And the bucketing is not as precise as 2 different pages on a slide deck, but it's a good way to think about it. And I want to start with Medicaid managed care, my third bullet. Most of the states that decided to expand were states that had robust Medicaid managed care programs. And they did their expansions through their Medicaid managed care programs. Minnesota's one such state, Arizona, New Mexico, New York, Washington State. They had robust Medicaid managed care programs working pretty well, and when they brought the expansion adults into coverage, they used those private plans that offered a Medicaid product to deliver services to their expansion adults. But that was by no means the only pathway, and so let's go to the top now and talk about something that Andy Allison's going to talk more about, but I want to give you a little bit of the framework. And this is premium assistance for QHPs, Qualified Health Plan. So Medicaid premium assistance allows a state to take Medicaid dollars and pay the premium for a commercial plan. To be precise, a QHP offered through the exchange or the marketplace. And Medicaid comes in, it says, look, these are individuals who are eligible for Medicaid. They earn $6,000, $8,000, $14,000 a year. We're going to buy QHP coverage. We're going to pay the premium. It's going to be the same amount as it's in the commercial market, and the individual will enroll in a QHP, and Medicaid will wrap around the cost sharing. So to the extent the cost sharing in that QHP may be higher than Medicaid law permits, Medicaid will cover that cost sharing. If there are missing benefits, and we'll come back to it, there are very few, Medicaid will provide the missing benefit. In fact, the missing benefits, the difference between Medicaid for the new adults and the QHP, it's really two things: non-emergency medical transportation and what we EPSDT, early periodic screening, diagnosis, and treatment for 19 and 20-year-olds. In its simplest terms, dental and vision for 19 and 20. To that extent, other than that, you see complete alignment between Medicaid and QHPs. Medicaid comes in, buys a QHP, Medicaid-eligible individual enrolls. They receive the same coverage as individuals who make more and enroll directly through the exchange, same provider networks, same conditions. The other benefit of this is that when that individual's income goes from $14,000 a year to $18,000 a year, and they're no longer Medicaid eligible, but they're eligible for tax subsidy in the exchange, they can stay with the same plan and the same providers. Interesting option, and one that has been appealing to several states. Most particularly states where legislators really wanted to morph Medicaid into the commercial market. There are other benefits, but I'm going to leave it to Andy to talk you through some of those. And we see several states, Iowa, Arkansas, New Hampshire, Pennsylvania has now proposed it, looking seriously or having implemented premium assistance. There's a second kind of premium assistance that's been around for a really long time, but becomes much more interesting in an expansion environment. And that's what we call premium assistance for employer-sponsored insurance. When you think about folks that are concerned about the expansion, one of the things you hear is, wait a sec, people will just drop their employer-sponsored coverage and come on Medicaid. And the answer to that can be not if you don't want it. Because what Medicaid can do is say to individuals, and this is what they're doing now in New Hampshire, they've done it in Iowa, is say to individuals, look, if you're eligible for employer-sponsored coverage, you make $14,000 a year, your employer offers coverage, you must take it up. And Medicaid will come in and assist by paying your co-premium. So if you can't afford that $120 a month that you have to pay through your employer to get employer-sponsored coverage, or the $60 a month, Medicaid will pick up the premium. Medicaid will pay co-pays and co-insurance above Medicaid permissible levels. Very similar to what I talked about with QHPs, but it's cost-effective for Medicaid because the individual doesn't drop their employer-sponsored coverage, and it works for the individual because Medicaid is assisting with the cost of coverage. So you have two types of premium assistance that are really in play now because of the expansion, and it is keeping, if you think about this, and now think about it back with Medicaid managed care. In Medicaid managed care, we're using private plans to offer a Medicaid product. In premium assistance for QHPs, we're using commercial plans, QHPs, to offer a Medicaid a product aligned with Medicaid, but it's a commercial product, and it's same thing for premium assistance for ESI, we're using the employer-sponsored market. But it's different ways of meshing the public and private sector coverage. For the most part, very much to the benefit of Medicaid-eligible individuals because there's an alignment across sectors. The last point I want to make is provider-led accountable care models. This is not unique to expansion states or non-expansion states, and it isn't unique to any one model. But increasingly, Medicaid programs are thinking of themselves as smart purchasers of health insurance. Medicaid's no longer a welfare program simply providing services. It's a purchaser of health insurance. And as a purchaser of health insurance, it wants to buy value. And so you're looking at Medicaid directors implementing patient-centered medical homes. I think that something like 41 states, Medicaid programs have patient-centered medical homes. Health homes for chronically ill individuals, 14 states, and you can have them in any of these models. Accountable care organizations, regional care organizations, again, Any of the first three models, it's integrated into it. You can do it whether you're expansion state or non-expansion state. Certainly if you're an expansion state, you have much more leverage to drive reform. But it's not limited to expansion states. So let's move from delivery models to what I call coverage models. And the features I'm going to talk about are the ones most under discussion by states now. They are emerging particularly in the states that are debating expansion. We could expand if we could get some of these things. And that's how I'm going to talk about it, but these are features that aren't necessarily conditioned to expansion, right? You could implement any of these in the context of a non-expansion. But interesting, it's the expansion decision that is driving the discussion of these features. And when I was thinking about my remarks, since I'm still on New York time, I was up bright and early, and I was thinking about what I wanted to say, and it came to me that as states debate these, there's three features they look at. They look at the political, they look at the philosophical, and they look at the practical. So what would fly in the politics of my state? What about the philosophy? You know, you've got it. I believe in skin in the game, personal responsibility. What's the philosophy that's driving it? And then is it practical? Now, I have to tell you, generally the debate ignores the practical. But as a former Medicaid director, and I'm sure my colleagues will say this, the practical matters because we can pass a piece of legislation, but it needs to be implemented. But I will tell you, practical tends to be a distant third. So think about these in the context of political, philosophical, and down at the bottom, practical. So benefits. Now, what the Affordable Care Act said on benefits for the new adults is they have to have the 10 essential health benefits. That's the same 10 essential health benefits that are in the qualified health plans. And so right away, you have the potential for alignment. The ACA went further, though, and it said, in addition to the 10, you have to offer non-emergency medical transportation and EPSDT, as I mentioned. So states are debating, do I want it to look like a commercial package? Will the federal government waive transportation and EPSDT? Yes, they will waive transportation. No, they will not waive EPSDT. But you can see there's a possibility for alignment. There are other states that say, oh, I can't have a different benefit package. Oh my God, how do I have one benefit package for new adults, another benefit package for the old adults and children? It doesn't make sense. I'm going to align with my standard benefit package. Those are choices that are very much driven by the 3 Ps that I started with. There tends to be less controversial around benefits. Premiums and cost sharing. Lot of attention. So before I talk to you about what's going on with premiums and cost sharing, I want to tell you what the federal Medicaid law says, because that's really has to be the starting point. This is what's in the law. What federal Medicaid law says is you may not charge premiums to individuals with incomes below 150% of the federal poverty level. No premiums. On cost sharing, it lays out the cost sharing scheme. And it has a different cost sharing rules for below 100% of the federal poverty level, individuals earning less than $11,000 a year, as opposed to individuals earning more than 11. By way of example, for an inpatient stay in a hospital, below 100, you can't be charged more than $75. Above 100, you can be charged up to 10% of the cost of the stay. Outpatient, below 100, not more than $4. Above 100, 10% of the outpatient visit. And in all cases, you can't be charged over the course of the year more than 5% of your household income. It's a maximum out of pocket. Much the way we have in the exchange, this is the maximum out of pocket in Medicaid. So states came in, and there were some very strong feelings about this, that we need to have premiums, we need to have cost sharing. And on premiums, CMS has granted waivers. So you see both Iowa and Michigan, Indiana's asking, Pennsylvania's asking, for premiums. And the way CMS reasoned was this. They said, yes, you may charge premiums to individuals with incomes above 100% of the federal poverty level, but those premiums cannot be more than 2% of their income. How did CMS get here? It's actually pretty rational. If you don't expand and you have individuals with incomes above 100%, they can purchase coverage in the exchange. And what does it cost them? 2% of their income. So they said, okay, we will allow states to impose premiums up to 2% of income. The issue then becomes, well, if the individual doesn't pay, will they be dropped from coverage or denied coverage? And CMS has allowed states, or the states that have asked so far, to drop individuals for coverage after a grace period, after hardship exemption. So with a lot of protections, CMS has said, yes, for individuals above 100%, you may impose a premium up to 2% of income, and under certain limited circumstances, if they fail to pay, they can be dropped for coverage. Now, Indiana has an interesting proposal in front of CMS now. They would like to charge premiums of 2% for individuals from 50% of the federal poverty level up to 100%. CMS has never permitted this. But the way they're doing it is really interesting, and I bet CMS approves it, which is they're saying, look, if you pay the premium, you get a better benefit package. We're going to give you all the additional benefits that are in our standard Medicaid benefit package, which includes dental and vision. If you don't pay your premium, you don't get dental and vision. So they get access to the Medicaid, they get all the required benefits, but they don't get the extra. And so that's how Indiana's going at it, and they've done it through a health savings-like account, which I'll come back to, but it feels like a premium. They call it a contribution. Now, what about cost sharing? CMS has virtually no ability to waive the cost sharing rules. The way the statute is written, and I will not bore you with the details, you can rail against CMS as much as you like, but they do not have the discretion to waive the cost sharing. So states are implementing cost sharing consistent with the statute, but many states aren't implementing cost sharing, and the debate that rages between the personal responsibility skin in the game on one side, and on the other side, the individuals point to the evidence that cost sharing not only makes individuals think about appropriately using care, but it also discourages, it prevents the appropriate use of care. So depending on where you come out on the philosophy and the politics, you're going with cost sharing or you're not going with cost sharing. And as we found in a few states, the practical is really a big deal here. It's really not so easy to implement, and is it worth the $4 or the $10? And again, this is a combination of all three when you make the decision. So we're definitely seeing more interest in premiums and cost sharing. Healthy behavior incentives, very much in line with personal responsibility. This is entirely permissible. CMS is going to look for evidence as to what the state wants to consider. You know, what's a healthy behavior standard? How will you modify it? Monitor it? What's the incentive if you meet it? All of that. But subject to that level of scrutiny, you're seeing healthy behavior incentives. And I think this is an area where we're going to see a lot more going on as states and policymakers really start to think what makes sense, because I don't think we entirely know yet. Now let's talk about these HSA-like accounts. HSAs, health savings accounts, came about in connection with high deductible plans. And it was a way for individuals to put money into an account, generally pre-tax dollars, which would then be available to cover their deductibles and cost sharing. And so the reason that some policymakers really want to move this into Medicaid is a sense that it will have individuals understand the cost of care, become more attuned to what it costs to deliver services. Now, we can't have high deductibles. We can't even have deductibles in Medicaid. And to the extent these HSA-like accounts use deductibles, and Indiana does, and Arkansas is moving in that direction. The HSA count is funded by Medicaid to cover the deductible, and the individual's portion covers the cost sharing or a smaller piece of it. So I will say to you, these are a pain in the neck to implement. We're trying to implement them now in a couple of states. They're really difficult, and I question the bang for the buck here, but it's philosophically very important to some people, and the notion of individuals understanding what the costs are certainly has some tractions. Work referral assurances. We can get rid of this one quickly. Pennsylvania came out, if you remember, and said, we want a work requirement. If you're not looking for work or working, you can't get Medicaid. CMS shot them down. That's not going to happen, but you are seeing states implement work referral requirements. That is, individuals should be referred to work, but there's no Medicaid penalty for not looking for work. The law is it's not a welfare program. Work is very important, but it can't be a condition for Medicaid coverage. My last point, and then I'm going to sit down, Larry, hopefully I haven't gone too long, is what we call state protections. I cannot tell you how many times we hear, we don't trust Congress. We don't trust the federal government. You know, they tell us now they'll never pay less than 90% for the new adults, for the expansion adults, but who can trust them? And so what states have done, and what is entirely permissible, is their expansion statutes provide that if the match rate goes below 90%, the expansion automatically sunsets. And a number of states have put in that protection. And it's sort of to fend off the, we don't trust Congress. The other thing a couple of states have done, I'm thinking about Michigan in particular, is they have provided that the savings that accrue to the state in the first 3 years when the federal government is paying 100%, and there are real savings as we substitute Medicaid dollars for programs that were state funded, mental health, inpatient care for prisoners, and the like. They want that savings put into a trust fund to cover the state share when the matching rate goes from 100% down to 90%. So I put that in here as a state protection level of comfort in enabling an expansion. So last comment. So where are we? Do we think that we're going to have every state take up the expansion in the next year? I think the answer to that is no. However, it took 17 years after Medicaid was initially passed in the 1960s for every state to adopt it. 17 years. So I think we should see a full expansion in less than 17 years, and for two reasons. One is I think that increasingly there's going to be a larger and larger disparity between expansion states and non-expansion states in their rates of insurance and in their health conditions. I think we're going to see more and more of that. We're already seeing it on the coverage rates. And I think the other side of it is the economics, and I would start with the hospitals. Again, hospitals in expansion states are reporting significant drops in their uncompensated care. So the economics, which will play out most visibly but not exclusively in the hospitals, will be something that policymakers will have to contend with. And in most states, the hospitals are a very powerful lobbying force. So for those reasons and many others, I do think over time, more states will move into the expansion category. So thank you.
So for those of you who are health policy geeks, this is like having Bruce Springsteen join us. I can tell you, because I've been...
Thank God I'm not singing for you.
I can tell you from traveling around the country and being in a bunch of states with policymakers working in health reform, that whether it's a red or a blue state or a purple state, Deb Bachrach is the gold standard. And I think you could see right here why. There's not partisanship here. It's very practical, and the level of knowledge from her work at the federal level as a state Medicaid director, so she knows the concrete issues, and now her work in many, many states, really provides just a unique resource. Thank you so much for coming out.
Thank you for those kind words.
So I want to pick up a couple themes. You move fairly quickly across a number of somewhat complex issues. So I want to pick up a couple themes, and then we'll start to have some of our other guests join us. Correct me if I've got this right. You seem to be saying basically in Washington we've got this polarization over the Affordable Care Act. It's yes or no, you know the parties. But when you go to the state level, it's quite diverse. And in some ways you have a lot of variation between red and blue states. But in a number of areas, and you were kind of giving some examples of that, both in terms of actually reforming delivery and looking at ways to address coverage issues, there's convergence, or at least there are themes of convergence. Is that accurate?
I think that's right. I think on delivery system reform, how do we pay for care? What do we buy? What are our quality standards? That's not a red state or blue state issue or an expansion state or a non-expansion state issue. I'll make a point I made before, is I do think that in expansion states, the reform can be more powerful, but I don't think by any means it's exclusive to the expansion states. I also think, and let's bring this back to coverage now, I think that if you're a state, you were my first group of states and you said, we're expanding. It's a moral imperative, it's an economic imperative. Your next sentence was, but we have to reform Medicaid. If you're a state on the other side and you're all serious, you said, we need to reform Medicaid before we expand. And so you can see right away how there's a synergy between the two. And one of the things that fascinated me, I just finished an article and interviewed Andy Allison in Arkansas, and we were looking at payment reform in Arkansas, and I'm sure Andy will say more about this. It's a statewide reform driven by Medicaid, and it started before the expansion. Expansion was not even in the minds of anyone, and they got it started through Medicaid as the driver. Having said that, from my point of view, it helped the expansion pass through a Republican-controlled legislature, and in my view, expansion jump-started or reinforced the payment reform. So you can see the synergy, and I'll let Andy say more about that, but as an outsider, it pointed out how the two things work synergistically. You then have Governor Perry in Texas who says, why would I expand Medicaid? It's the Titanic. So I don't know that he's quite in the realm of, if we reform, we can then expand. But I think for a large number of states, red and blue, the two things go really nicely together.
This is a really important point, I think, and I want to it seems pretty obvious why once you're on the let's expand coverage, you get into reform immediately. It's a fiscal necessity. Walk us through the other way. Why is it if you are a state that goes into this saying, we have to reform Medicaid, that you would start to look at coverage expansion?
I think for the very simple reason, in some sense, Larry, I was sort of what I was getting at, right?
Yeah.
Which is, if you don't expand, and let's just say, you're covering parents to 30% of the federal poverty level, and her income goes up to 35%, you just lost her. So, your ability to influence people's health is dramatically reduced if you don't expand. And so the pressure to, I think, expand comes from the desire to make a difference in the health of low-income individuals and to drive delivery system reform. And I should also say, remember, Medicaid's a big cost factor. Remember, nobody doesn't know this, in every budget, whether you're an expansion state or a non-expansion state. So to the extent the individuals you're covering are age blind and disabled, those are your most expensive beneficiaries, and you're going to be thinking about how to better serve them for clinical reasons and economic reasons, whether you expand or you don't expand.
You talked about coverage. But one of the things I'm wondering if you could talk a little bit more about is your discussion of coverage and the expansion tended to focus on the eligibility level. and states that went in for the Affordable Care Act, bringing the non-elderly adults up to 138% of federal poverty line. Could you explain some of the other ways in which Medicaid has been involved in expanding coverage, for instance, the modernization and some of the enrollment efforts?
Yeah, I actually neglected that entirely. I mean, there's a second part of the Medicaid expansion, or a second feature of the ACA, which really I skipped right over, which is, if you think that Medicaid started as a welfare program, so we thought about it in the 60s, the way we think about cash assistance, not a good thing, and we want to get people off of welfare. Medicaid, on the other hand, is now increasingly becoming a coverage program, an insurance program. So when we started out with Medicaid, we thought about it like welfare. We don't want people on. So in order to get on Medicaid, we'd require individuals to come in, and this, I'll give you my New York example, with 4 consecutive pay stubs. Now, they came in with pay stub 1, 2, and 4, but they were missing 3. We'd send them away so that they could get 4, 5, 6, and 7. We made them come in and prove they didn't have assets. So every step of the way, fingerprinting, face-to-face interview requirements, it all came from the welfare mode with the idea that we don't want people to have Medicaid. And what the ACA did, we've been seeing states moving in this direction, but in one fell swoop it said, no, we're not going to have document requirements. You're not going to have to come in with 4 consecutive pay stubs. We now have the ability to do that all through IT systems, or we're hoping to have them available through IT systems. That's the goal, right? But so it changed the paradigm, and it moved Medicaid from a welfare program, which we don't want people to have, to an insurance program that we want people to have. And that paradigm shift was implemented through a lot of rules that nobody except Medicaid directors pay a lot of attention to streamline the eligibility and enrollment system.
And this has happened in nearly all the states.
This is happening whether you expand or you don't expand.
I mean, this is the kind of hidden, I would say, the hidden story of Medicaid. And, to be fair, it's not the many millions from the ACA expansion, but it is substantial, and in states like Texas and
well, I think you're going to start. I mean, look, virtually every state had problems with their IT systems. So the gold standard, which is you can apply online and have a real-time eligibility decision, whether you're Medicaid eligible or tax credit eligible or eligible for none of those programs. That's what we're striving for. And we brought the standard. So the same standard now applies for the person who makes $11,000 a year and is eligible for Medicaid. We calculate their eligibility the same way we do for someone who earns $30,000 a year and is eligible for a tax credit.
We're going to bring up some of our friends in a second, but before we do, I want to ask you about a concern at the outset once the law was passed and folks were starting to worry about some of the problems. Some didn't develop, some developed that we didn't anticipate. And one of those big issues was this issue of churn, which is that folks would move between systems. You'd be on the exchange, but there'd be some change in your life circumstances and your wages, and you'd drop down to a level where you were back on Medicaid. And can you give us a sense of how much of an issue has this been from what you can tell so far?
This is really an interesting question, because when the ACA passed in 2010, I spent 2010 and 11 writing on this topic, speaking on this topic. I'm looking at Andy. We were completely engaged in this continuum of coverage. And then it dropped off the radar screen. Why? Because we had to implement, right? And I mean, we couldn't worry about the continuum of coverage. We had to get people on coverage. And it really got back-burnered. And it's just, I don't think it's fair to say it has reemerged. I think it's just about ready to reemerge. We've got to do renewals for everybody. We've got some more implementation issues, as we all know. But I think that this will come back on the radar screen. We will have the opportunity, if not the imperative, to start to think about that continuum of coverage. So as your income changes and your subsidy changes, from Medicaid or here for basic health plan or tax credit for QHP, you're not going to have to drop off coverage, find another plan, or even go back and refine the same plan. How do we do it so it's seamless to the consumer as to the basis of their subsidy? And I think we're going to come back to that. It may not be for another year or two, but I don't think, at least us policy wonks, will ever let go of that.
Thank you. We're going to invite several state Medicaid commissioners to join us. And I want to just preface it by saying part of what we wanted to do today was to have the national mapping that comes with Deb Bachrach's expertise that you've been witnessing, and then bring in some folks who are working in states. And in states where you have Republican legislatures or Republican legislature and a Republican governor. And then we're going to have several folks from Minnesota, including Commissioner Jessen, who's here with us today. I'd like to begin by inviting the former Medicaid Commissioner Director in Arkansas. The Arkansas reform is really a trailblazer in terms of the kind of innovation that Deb Bachrach has been talking about. Andy Allison, thank you so much for coming. We appreciate it. It's a fielder's choice.
Okay, let me just talk from here, since I don't have a visual presentation, and speak for no more than 5-10 minutes, and hopefully we'll have questions later and time for interaction. Thanks for the opportunity to be in Minnesota. I'm not sure I've been here since I might not have been more than 16 years old, but my dad worked with folks at the University of Minnesota. And we drove through once for that purpose. So I want to say things that you'll remember. And here's why. Because this is a big prediction that we're making, right? States decide whether to expand Medicaid based on the prediction of how much it will cost, based on the prediction of impact on people's lives. There's really, strangely enough, debate about whether health insurance matters to somebody's health. Just a crazy discussion, but you know what? The statistical proofs have been difficult so far. They won't be in a few years. We have right now a dramatic natural experiment taking place on the impact of Medicaid expansion, because essentially the only reason some states aren't is political. And that means you can measure what happens in one state versus another with pretty much certain statistical clarity. That's going to happen in the next 2 or 3 years. It's why I don't think it's going to take 17 for the rest of the states to sort of be convinced that they're harming poor people by not expanding. Arkansas did, and what I want you to leave with, and the reason I stood up to say it, is that you not leave thinking that this was just a political compromise. If it was just a political compromise, then 2 or 3 years from now, you won't see that Arkansas's individual private insurance marketplace is more competitive than an individual private insurance marketplace has ever been in a state like Arkansas. Ever. If it's just a political compromise, then it won't have had the leveraged impact on health system reform that it's going to have, in particular in primary care. And I'll say something about that. Let me reinforce mechanically so you understand Arkansas is what we call private option, so named because it's the opposite of the public option. Rather than putting a public payer in competition with private carriers in the marketplace, Arkansas is literally buying from those private carriers in the marketplace, and there is no alternative Medicaid, even for those individuals, with the following condition. And I want to amplify Deborah. You should know that Deborah worked with us and helped implement the private option as a expert legal and other providing other expertise to Arkansas over the last couple of years as we did this. Mechanically, here's how it works. You apply for coverage, which means you demonstrate that your family structure and income meet that criteria, 138% of the federal poverty level, which is a concept and people don't know where they stack up until they go through this hopefully electronic process, and we're halfway there in Arkansas. Immediately after that, and also electronically, we give to individuals, if they're below that 138% line, we administer to them a health service needs screener online. We ask them what their health is. We ask them if they have had exceptional needs over the past 6 months, used a lot of health care, have they had a couple of nights in a hospital for psychiatric purposes? Do they have needs in the area of activities of daily living? Do they live independently? We found out in the first 2 months, 700-800 homeless individuals signed up. How did we know this? Well, because we asked. And if you are not living independently, if you do have those exceptional needs, if we think you're going to need more than the 10 essential benefits that Deborah described to you, we give them to you over here in the Medicaid program. If you don't need those other things, then we take and put you in and give you a choice of the silver tier health plans in Arkansas's marketplace. We told the carriers that we would target a 10% rate of screening positive for exceptional needs. Another terminology is medical frailty. Try not to use that too often. It's a federal term, and I never try to use federal terms. And so what we did is we told private sector, no offense, corporate insurance actuaries who have no idea how this works, we needed to give them some certainty. And here's the certainty we told them they would have. You don't get the highest 10% needs on a predictable basis, individuals. We'll take them. What does that leave the insurance marketplace in Arkansas? It leaves them with the following. To date, 4 times as many individuals in that marketplace as there would otherwise be. Healthcare.gov was unsuccessful enough. Arkansas's expansion was successful enough that right now, today, the private option buy-in population is 3 or 4 times as large as the individual buy-ins to the marketplace. Number 2, they're 8 to 10 years younger. Why? Because age and income are systematically related. You know this from your own life, unless you were born rich, that you have more income now than you did a year ago on average until you hit about age 50 or so. That's when it peaks. But at the young ages that have a hard time participating by choice, we have just deposited in Arkansas so many young, poor people in that marketplace that the marketplace itself has an average age 8 years younger than it would otherwise. 8. We have just made Arkansas's marketplace bigger, systematically healthier, and dramatically younger than it would otherwise be. Which is why I say mathematically, it almost has to be the case that in a couple of years you're going to find that Arkansas's private individual health insurance marketplace is potentially more successful than any private individual marketplace in the history of the country for a state its size and demographic. It pretty much has to be unless it's mismanaged. That's what I want to leave you with. Don't be surprised when the data proves that out. You'll know either this fall or next fall. You'll know this fall that we have more statewide competing carriers in our individual marketplace than our surrounding states, who are by and large bigger than we are. You'll know because premiums either go up because the carriers and actuaries think that that risk pool is getting more expensive, or they don't. Or maybe they go down at some point in the next year when those actuaries do learn what it means to have a much younger and much healthier population in the marketplace. That's eventually going to happen. It's math. So you just wait. When that happens, don't be surprised. So point number 2 is the leverage. Before the insurance marketplace was established, before the private option happened, Arkansas was already engaged at Blue Cross, by the way, was an instigator in this before I arrived in the state, in multi-payer payment reform. It's episodes of care, and it's in particular, I'll refer to the patient-centered medical home. where we are paying physicians the extra cost of managing care, and we are paying physicians for the savings that that management is going to bring, shared savings. We are not doing this through big, massive systems like Mayo, which do it really well, but do it for a different population. We're doing this for all the docs. Arkansas is rural. Statewide, we have hundreds of primary care physicians already signed up for this program. It began in January. But the problem is that a primary care doc has difficulty changing the way they do business if it's just for Medicaid, and in particular, if it's just for some sort of 3-year experiment. So Arkansas's law establishing the private option said all of the carriers in the marketplace, meaning all of the patients and covered lives in the marketplace, will have a patient-centered medical home that looks, in the end, it will look like the Medicaid one. We just took multi-payer payment reform to scale. We just gave primary care docs the confidence that they're actually going to get paid for their investment in a care manager or a different way of organizing literally the physical space in their clinic to manage care. Hundreds of thousands of lives, we're a smaller state, but hundreds of thousands of lives invested in and paid to be a member of a patient-centered medical home, guaranteed in law, not an experiment, all payers. That's enough to have drawn, by the way, Walmart, our biggest employer in the state, into the fold as one of those additional voluntary multi-payer participants in the patient-centered medical home. Our aspirations were not just to transform Medicaid, we've done that. Our aspirations were not just to expand coverage, although that would have been enough. Our aspirations were to transform the health system of the state. We feel like we're on path. I will take questions. I'm sure I've taken my time.
Please join us, Andy. So, just to kind of put this in perspective, what you've just talked about was enacted in a state where the legislature is Republican controlled, they're the majority, and in which there's a constitutional rule that you need 75% of legislators to sign off. But just pause and think about that. So here we have this paradigm in our minds about national politics on health reform, where it's absolutely deadlocked, in which you can't get anything done. Here we are in a state, there's a Democratic governor, but you've got, I would say, pretty severe tests for passing legislation, and you've got a strong, independent, Republican-controlled legislature, and you've adopted a variant of the Affordable Care Act. So tell me, do you feel like the innovation in Arkansas is political, and how you pulled off what I just described, or is it policy, or is it both?
One of the reasons I took the job in Arkansas, I had been in Kansas. Just let that sink in. And survived the transition, by the way. I did work for Governor Brownback for a few months. Until the Arkansas job came along, and I knew enough about Arkansas from my past and my family that I knew that they still thought that they could come together as a state to do something and make a choice. They have an identity as a state. They know that they are Arkansans. And I knew there was a possibility they could choose to do something pragmatic. I had no idea that the legislature would flip for the first time since Reconstruction in both chambers to be Republican. Had no idea that Judge Roberts would make his decision, that then I would be faced, and our whole team, of course, with the challenge of obtaining 3/4 votes, which means a majority of the Republicans in each chamber 2 years in a row to decide to expand government in the biggest way in history in that state. I don't think those two things are unrelated. Just simply, now, I still have gotten to know those key legislators in that new leadership role pretty darn well. They placed a bet themselves. They placed a bet as Republicans because they're young. Their futures politically are ahead of them. You can interpret the bet yourself. But in the end, what Arkansas did is to take, lemons and make Mike's Hard Lemonade from it.
It's also interesting, and you said this, but I want to just kind of pull it out a little more. The sequencing of reform in Arkansas was interesting. Beginning, I think, in 2011, there was a serious conversation with stakeholders in the state about reform of the sort that you were talking about: coordinated care, payment reform, delivery reform. And then you get to the access part. And so whereas Deborah and I were talking about the access expansion as a way to drive reform, it seems as if Arkansas is a really good case where the focus was really on how do we, as you said, transform our healthcare system.
Absolutely, and the debate over how to transform the health system was that's actually why I was hired, because I was hired before the Medicaid decision in the Supreme Court, was to help sell and take to scale the payment reforms. And very lively debate with, along some of the same ideological divides over whether Medicaid could lead payment reform for the state. And we really came into the 2013 legislative session facing both the need to sell and validate the payment reforms in the form of the legislature acceding to what we were doing sort of regulatorily through Medicaid, and sell expansion at the same time. And in the end, they were written into the same piece of legislation together. I of course, completely agree with Deborah on this point. And those legislative leaders, those young Republican leaders, will tell you, yes, it was a package deal, and that we could not simply expand Medicaid, which we didn't, of course. We shrunk the traditional Medicaid program back to, in its view, its original purpose: special programs and services like long-term care, behavioral health, and developmental disabilities for special populations. In the end, that's what Medicaid will look like. And that's all Medicaid will be in Arkansas, and they thought that made perfect sense. Take Medicaid back to its original purpose and leave to the private market what it could do. This was all a package deal, and they knew, of course, fiscal prudence tells you, let's pay attention to whether we're bending the cost curve up or down in the process, and they cared about that direction.
One of the conditions, I think one of the two conditions that the federal government put on the waiver for Arkansas's premium assistance model was that the total cost of the reform not be more than the expansion of Medicaid, the traditional Medicaid program. Do you have any evidence or even anecdotal sense of whether you're going to reach, I think it was $90 million target or something close to that?
Well, I have another prediction, so we're living in this very long stretch of time, which began, depending on how you count, at least a year and a half ago, if not longer, where the cost of a marketplace insurance product, which is what we're buying through with Medicaid dollars in Arkansas, is an actuarial prediction based on an unknown population and their accumulating but relatively unobserved health risk. And in Arkansas, at the same time, we're creating a new and completely blended marketplace where you would expect that you don't quite have to pay traditional commercial rates of reimbursement to generate access. If the alternative is the Medicaid rate down here, maybe you end up with something. We have rates that are floating in space that are a prediction. We have demographic and health risk, which is a prediction. We didn't know exactly how many people would be participating. What do I believe? I believe that health plans were immediately able to negotiate some discounts with providers, which will sustain as long as they aren't politically overturned through marketplace regulation or other pressure. We know the demographics are way better. We know that we're pretty sure the insurance companies, we're pretty sure they couldn't possibly be spending all the premium money we've been giving them. But yes, in the end, this will be a cinch. We'll meet our budget neutrality target by a lot, not just a little bit.
Deb, do you want?
Yeah, I want to
oh,
jump in on two things. One is that something that we haven't said, but is also true, is that the hospitals and the providers really like treating Medicaid patients through qualified health plans, so that their reimbursement rate is the same whether the person makes $10,000 a year or $40,000 a year. And it works for the providers. The other point I want to make, in some sense it's simplistic, but it's one that drives me crazy, is that you hear folks, you hear members of Congress stand up and say, well, the private option isn't going to work because Medicaid could get it for less. You're paying more than you'd have to pay for access in Medicaid. And then the next day they say, well, nobody will take Medicaid because it doesn't pay enough. So that if we believe that to have access in Medicaid, we have to bring Medicaid into the commercial market on some sense. The private option does that in the most rational way possible. And so I get so frustrated because Medicaid is criticized for not paying enough, and now Medicaid is criticized for paying too much. And we have to sort of decide what we want.
Excellent. We could go on for
Yes.
a long time on this. I want to invite Brett Davis, who was the Medicaid director in Wisconsin for Governor Scott Walker. Wisconsin is one of the really interesting and important pioneers, and again, different variant. In Wisconsin, Governor Walker rejected the Affordable Care Act, but he nonetheless pursued a reform that ended up expanding coverage. Please welcome Brett Davis.
Thank you very much, Larry, for the kind introduction. I appreciate this. Set this aside. Clearly, I drew the short straw today, as you can tell, having to speak after these two fine presenters and thought leaders in healthcare in our country. It's always a pleasure to be with you guys. Larry, thank you and the Humphrey School for organizing this. I know it is not easy to pull these types of forums off, but it's always intellectually stimulating, and I always learn something. So hopefully I'll be able to contribute something today, and you can take away something as well. Scott, thank you very much from Blue Cross for helping with strengthen the partnership with Larry and the Humphrey School. I know those partnerships exist in Wisconsin as well, and I know how valuable they certainly are. And Representative Dean, thank you for taking time out of your busy schedule to be here today, and Commissioner as well. I come at this with a relatively unique perspective that I'm developing. I was in the Wisconsin State Assembly in the legislature for 6 years, 3 terms. And so I came at it from that perspective. I was on the Medicaid Reform Committee back in kind of I was elected in 2008, so around 2010 I was in the Medicaid Reform Committee. Prior to that, I had worked for Governor Thompson when he became secretary at the U.S. Department of Health and Human Services. So I had that federal perspective as well. And then I became the Medicaid director for Wisconsin over this historic time, overseeing the transition from our plans, which I'll describe in more detail, through the Affordable Care Act, and was helpful with the governor making the decisions and where we're at today. So it's certainly a unique approach that I want to talk with you about, and I think of it as the Wisconsin approach. I don't think of it necessarily in terms of expansion, non-expansion. I think of it in terms of what problem are we ultimately trying to solve. And every state's very different. Andy and I talked at a forum that we were at before. It's really all about your starting point. I think Arkansas started out at 17% coverage for parents and caretakers. Wisconsin was at 200% of federal poverty level coverage for parents and caretakers. So that starting point ultimately makes a significant difference. But let me take a step back and talk about what goals we had back in 2012, 2011, 2012, and into 2013 that we ultimately implemented. When I was in the legislature, oftentimes I found myself even, and I'm guilty as charged, and I observed other legislators trying to create solutions for problems that may or may not have existed. But you had to connect with your constituents. You had to develop something to sell to them to make sure that they knew you were working very hard for them so you could continue to get elected. So oftentimes, good, very well-meaning and well-intentioned individuals would come up with some ideas, and as Deb alluded to earlier, not so practical. So when I became Medicaid director, I soon, found somewhat of and I say this semi-jokingly, I know them all, sort of a disdain for the legislature and my former colleagues for saying, boy, that HSA idea, love it, love the concept. Yeah, I ran on it for 6 years, but sorry, we can't implement it right now. So it was all those types of conversations that we had. So when I became Medicaid director and was working with the governor's office and our team at the Department of Health Services, we said, what are we setting out to solve? What problem are we trying to solve? Because I think oftentimes as a country we can get wrapped up into expansion, non-expansion. How many people do you have enrolled in Medicaid? How many people do you have in the exchange? But I think that's too much of a simplistic approach. For us in Medicaid in Wisconsin, our approach was, first and foremost, we wanted to reduce the level of uninsured. That was the Governor Walker's first goal. For the 19 to 64-year-old population, he wanted to cut the uninsured rate in half. We wanted to take it from 14% in 2011, and we wanted to drop that to 7%. Very specific, very targeted goal. We were able to coalesce around public-private partnerships across the entire state, and I believe personally that we're very well on our way to making that happen. And I'll describe a little bit more about our plans and how we got there in a second. Second goal for us was to provide people with the benefits that they actually needed to improve their health care, their quality of life, and overall well-being. And so oftentimes it's not spoken of in the national media in particular, but one of Governor Walker's goals was to actually provide people with enhanced level of benefit coverage, especially for childless adults. Beyond the essential health benefits, the 10 essential benefits that are in the ACA, Governor Walker decided he wants to double down on the population that's going to need the help the most. Childless adults. We knew that, yes, in Wisconsin, we have a substance abuse issue problem in times. We have, on Medicaid, a lot of folks with mental illness that needed help. And that's true in every state across the country. So the governor decided to say, look, beyond what the essential health benefits package is, we'll offer up mental health services. We'll offer up preventative dental services for the first time in our state's history for those individuals that are coming onto Medicaid. When I left Medicaid in mid-March and then the April statistics, they ended up being around, it was about, when I left it was 16,000 or 15,000 childless adults that were on the program because we had a cap on our program. Just 3 short months later, 97,000 childless adults have access to health insurance in the state of Wisconsin. A significant feat. A significant feat. And for the first time in state's history, every single individual in Wisconsin has access to health insurance. That's why we don't fit cleanly into the expansion, non-expansion state, and we focus on positive problem solving and what goal are we ultimately coming up on. And I'll describe in a little more detail. Our third goal was to accelerate the increase in healthcare value. Every state, every individual, I could ask every one of you in this room, what does healthcare value mean? Quality over cost. You could sprinkle in some appropriate use criteria. Somebody can come up with a different equation. But ultimately for us, it was defining what healthcare value was for very specific populations, wrapping projects around them, and then measuring success. And then learning from it, and then moving on in the classic Wisconsin way. So those were really our 3 goals: reducing the uninsured, providing enhanced benefits, and accelerating the rate of reform. So our starting point in Wisconsin, again, was 200% of the federal poverty level. And that was for childless adults. They had a cap on the program. Under Governor Doyle, it ended up being there at 50 to 65,000 individuals, and then because of budget issues at the time, through attrition, when people came off, they weren't backfilled, it slid back to about roughly 15,000 individuals before I left. And we also had parents and caretakers up to 200% of the federal poverty level, and we had children up to 300% of the federal poverty level. Actually, children could buy into the program unlimited, and then in the last budget before I left, we put a cap on that program, and pregnant women had access up to 300. So in Wisconsin now today, children and pregnant women still have access up to 300% of the federal poverty level. Childless adults and parents and caretakers, we dropped the FPL levels from 200% to 100%. And that was probably the most significant change, and that's really where the debate is centered on in Wisconsin, especially between the 100% of FPL and 133. It's notable to me that the debate isn't about 133 to 200. Everybody forgets about that piece and says, well, let's not worry about that. It's really over, well, we've got to expand and get the federal dollar. And so over a majority of the people that transitioned off the program were actually from the 133 and above, but that's not always talked about in the state of Wisconsin. But we were able to, through aggressive outreach efforts and standing up 11 different regional enrollment networks, partnering with our counties, partnering with other associations, and partnering with some national organizations as well, we were able to send out over 200,000 letters at the Department of Health Services and make over 300,000 follow-up phone calls during that transition. A historic outreach that It was unprecedented in the state of Wisconsin and continues to today. So we were able to build that infrastructure, and that's one point I always emphasize when I speak. Building that infrastructure for enrollment and outreach is a continuous process that needs to be fine-tuned over a period of time, and I think in Wisconsin we're doing well and well on our way. And I talked a little bit already about the benefits people needed, but it's an important point to reiterate. Childless adults for the first time are getting mental health services that they didn't have access to before, except for going through the emergency room. And oftentimes there were shortages after that. So the quality of life for several individuals in the state of Wisconsin is enhanced greatly. And there's additional evidence about oral health and the connection to the overall health and well-being. And it was through some of those early studies that we felt it was important to get people access to preventative dental services and just be very proactive in our approach. And that was a key form. We needed to make sure that providers had the tools they had to serve them. And we needed to make sure people had that insurance card in order to initiate some of the reforms that we had. One of the first things I did as Medicaid director in Wisconsin was line up the individuals that were in some form of managed care. Now, people can argue, is managed care good, is it not, which delivery reform model, and Deb, I love that slide up there, and I might steal that sometime.
You got it.
And I love those reforms, but oftentimes, regardless of how you organize the chairs, sometimes the results are the same. I remember Tony Keck from South Carolina did an analysis for one of our Medicaid conferences that showed, well, provider-led or HMO-led, the difference is you still have to have an admin load. There's still certain functions that have to be performed. You may have kind of the same thing. So it was an interesting approach, but we had to make sure that those benefit levels ultimately were there. So we lined up fee-for-service and Medicaid managed care, and we isolated and lasered in on the populations that were still in fee-for-service. And what we found was intriguing to me. We still had people, we were so focused on accelerating, getting people enrolled that we forgot to take care of them once they were in the door. So we got them through we got them into the house, but we said, all right, now you're on your own. So it was that effort over the 3-year period that I was there to really try to isolate, and we put us on what I will argue is probably a 5 to 7 year trajectory of building the infrastructure, the databases, the systems connections that have been cobbled together with paper clips and duct tape over time to actually manage the total cost of care of an individual. Novel concept, right? This is what everybody thinks is happening across the state. It's not easy. Not easy to do, to have a member ID to trace that through every system. And regardless of when somebody's born, if they're on Medicaid, all the way through death, we should be able to track. Right now they bump into siloed programs. And if you have long-term care, we're going to send you over into this line. And if you have health care needs, well, you got to go over here. Well, no wonder people don't get services. We have to start thinking of members and citizens first and wrapping around those programs. And again, it's easier said than done. In Wisconsin, we worked on behavioral health. Similar things are happening all over the state of Minnesota. I'm always impressed, and I always learn something from the projects that are going on in Minnesota. But we did a behavioral health integrated care model that was trying to wrap our total cost of care concept over individuals with behavioral health and substance abuse issues. We focused another project down in southeast Wisconsin. We're working with the National Governors Association specifically to focus on the high-end users of emergency rooms or higher cost individuals, similar to what's happening in Hennepin County here in Minnesota, and who's doing terrific work. They came to Madison and spoke with us and shared some of the lessons that they learned. We're also working on have instituted a medication therapy management, not a full total cost of care, but the design there was how do you get pharmacists more involved in a person's life. I felt like some pharmacists are some of the smartest people in the healthcare industry, but yet they're woefully underutilized. So how do we build not only the capacity for them to sit down in every hometown pharmacy across the state of Wisconsin, but then also eventually phase 2, 3, or actually phase 4 or 5 is going to be how do you connect those systems? How do you connect the local community hospital with the system that they have in their pharmacy, and how does that connect back to Medicaid? So we can actually push real-time information out to them, flag those individuals, and actually get them the care that they need. Those are all the types of reforms that are going on in Wisconsin, and it's not unique. A lot of these ideas are happening all across the country. But I say all that because it's really designed to solve a specific problem. Healthcare costs were going up at rates, Medicaid levels were unsustainable. Our uninsured rate was too high. Better than many states across the country, but for us in Wisconsin, we want to get every single person covered. Now, we want to take measure and be practical about it, so we said we'll cut it in half and not solve all the world's problems in day one. but we're taking significant steps forward. So hopefully you can see that we're taking a very pragmatic, positive problem-solving approach in the state of Wisconsin to get people covered and gain access to cut the uninsured rate, to get people the benefits that they need to actually live healthier lives, and to accelerate the value of healthcare reform and that healthcare value for those individuals in the state of Wisconsin. So I appreciate the opportunity to speak today and would love to answer some questions.
Great, thank you very much. So I'm going to open up in a second to Deb and Andy, and invite them to ask any questions or explore some issues. I want to kind of come at one of the core issues you raised. Clearly, the work you did and Governor Walker have made progress towards the goal of reducing the uninsured rate by half. That's clear, and it comes from several factors, including the expansion of Medicaid coverage to the childless adults who weren't covered before, the 97,000 you talked about. Plus, there were a number of individuals who picked up private health insurance either through the exchange or off the exchange. And so there's a real record there. There are some concerns, though, and there were some numbers that just came out recently, that the model that you worked on was to reduce the coverage for those who were between 100% and 200% of the federal poverty line, with the thinking that those people would then get covered through the federal exchange. And you'd hoped and expected that that might be around 90%. It turns out that that number so far has been about 30%. Couldn't you give us your sense of, is that just kind of startup, hold your horses, let this play out for a few years? Or do you see this as maybe pointing to some more significant challenges in getting that part of the Medicaid population to use the exchange?
Well, you had to bring up the tough one first. No, I very much appreciate the question, and it's something that I've been contemplating, and I think it's a subject of a lot of debate, especially in the governor's debate, I think, over the course of the next several months. Some of the statistics that you threw out were very well accurate. Let me just frame it a little bit as well, and I alluded to the numbers. So we had 62,000, little over 62,000 people transitioning from Medicaid into the private markets. Then we had 18,801 people that signed up for qualified health plans. So that leaves you with 43,975, if I'm doing my math right. Andy's an expert in this. But 34,000 of those individuals were over 133% of the federal poverty level. So, I mean, when you throw out and we frame the debate about certain things and take-up rates, I think you have to dissect it. In Wisconsin, the debate's not about 133 and above, because that reform was going to happen, and those people were going to transition anyway. So those 34,000 people were going to be transitioned into insurance. So for those individuals and the 9,000 or roughly 10,000 individuals that are left, I mean, our focus has been on outreach and connecting them to overall coverage. And how do we do a better job within the regional enrollment networks? How do we do a better job with the qualified health plans and outreach and overall and being aggressive those ways? So I think when you look at over 1 million people on Medicaid, and we're talking, the debate's surrounded around between 9,000 and 10,000 individuals. Now, if you're one of those individuals, that's everything. And I 100% get that. So I'm not trying to minimize that in any way, shape, or form. But this was an opportunity to fundamentally reshape and reform what Medicaid is in Wisconsin. And Governor Walker decided that, it was in our best interest as a state to move forward with Medicaid being defined, except for children and for pregnant women, which is 300% of the federal poverty level, define it as for people that are living in poverty. And anyone above that can have access to qualified health plan coverage, pay minimal deductibles and coinsurance. We estimated at the time it was going to be about $5 a week for individuals, right around that 115 mark. So we felt that that was a fair amount of money to pay, and we felt that we could move forward. Plus, and Deb alluded to this earlier, but the uncertainty of short-term and in Wisconsin money and dollars combined, and it's the fiscal pressures, the debt that accumulated, the lessons learned in Wisconsin about how you can run up debt, and looking at the federal government, and some of that uncertainty still and definitely did play a factor into it.
So I'm going to pick up on Deb's 3 Ps. Politics, philosophy, and practicality. And I loved your comment about moving from the legislature into the Medicaid director, and practicality goes from, well, third place to first place.
Yes, it does.
So I want to ask you, as both a administrator and as someone who served in the Wisconsin Assembly, to walk us through why it was, if the purpose was to reduce the uninsured rate, that Wisconsin didn't expand the Medicaid, perhaps through a sort of premium assistance approach that we've seen done in Arkansas and Iowa, and perhaps the Republican governor in Pennsylvania is going to get his approved.
Because we had our own track. Again, it's your starting point. There was momentum going on there. I mean, that's the beauty of America. It's a laboratory of experiments that are happening. So Andy was leading that effort down there. We looked at our starting point and said the solution for Wisconsin is what I defined earlier. And in the legislature, the $5 a week is personal responsibility. I mean, that's what people will say. I mean, if I walk through the streets of Monroe where I grew up and I told them, should Medicaid, should individuals on Bachrach, should they pay $5 a week? They'll say, heck yeah, I can't believe, why isn't that happening? And I get a different answer maybe when I go down in the city of Milwaukee, potentially, but I mean, it's what we hear.
No, I think you're right. Starting point is everything, and you've made that point very clear. It's interesting, though, in Arkansas, again, Republican legislature, they went ahead and did a variant of the Affordable Care Act with the Medicaid expansion. They took the so-called savings and put it into tax cuts. So, you kind of look at the money that, and you might not like this phrase, but that Wisconsin decided not to take from the federal government, the 100% for 3 years, the 90% afterwards, and the ways in which some Medicaid directors have shifted their pools around to take advantage of that. And you could see some advantages here, even for kind of a conservative Republican government.
It's a good point. I mean, you can sprinkle in some tax cuts to sell it. You can put on bells and whistles like they did in Michigan for HSAs. In Pennsylvania, you can put work requirements on. I mean, I could put a Christmas tree package together to sell pretty much anything, ultimately. But in Wisconsin, it wasn't going to pass because it's Medicaid expansion. I mean, Andy and I have had this conversation, and it's a private option, and I get that. But technically, through the state plan amendment, it is Medicaid expansion. That's why it shows up there in yellow on the map.
That's not my color.
And that may not be his color, but I mean, he's got a different blend. But in Wisconsin, the legislators knew that, and it wasn't going to pass. And so, plus the amount of money, I mean, we did an analysis to show how much money we would have to increase premiums ultimately. And Andy and I have had this discussion as well, and it probably wouldn't have been doubled. But Medicaid rates were about half of what the commercial premiums were at the time. Significant amount of money. And so the federal government would have had to pay out that much more money at the time as well. I don't think it would have been double. I think it would have come down closer, maybe around Medicare plus something ultimately, and that may be where they end up settling in. But it's not as easy as just saying, well, it should have happened there, and how did it happen in Arkansas, and it didn't happen in Wisconsin?
Yeah, I do want to jump in. So, in some sense, this is a comment, which is in states that have done expansions through Medicaid managed care, they have Medicaid managed care. To your point, we didn't think it made sense. If you have a robust Medicaid managed care program, why would you use premium assistance? The private option. But what we found in some states is the politics commanded it. So in New Hampshire, the governor preferred to use Medicaid managed care. And she said to the legislature, okay, you like this private option, let's just do it for folks above 100% of the federal poverty level, like in Iowa. The legislature said no, for us to expand. In some sense, Brett, it's what you're saying, for us to expand in New Hampshire, for us to be able to vote for it, we need to use private plans and meld Medicaid into the private market. We don't want to do the separate approach. And so we're seeing very much a melding of what can work informed by the politics.
I would just add to that. It's depending on who, where you stand, where you sit. It's either really hard to win a prediction or really easy. We're living in an extended period of prediction about how these various models, how Medicaid expansion, how the reforms are going to turn out. We won't live in the world of prediction for very much longer, no more than 14 months. potentially as soon as 2. And hopefully the states, that's why I don't think we'll get to 17, but by the time we get to 3 or 4, we won't necessarily be living in the land of prediction anymore. It'll be a little easier to sort of have the conversation. Because that's exactly the conversations that were happening in Arkansas in the hallways and behind the scenes. That was the debate. We got right past the question of whether we'd save the state money. That took about half an hour. I won that, 8 months before the debate started. The argument that was difficult to win was how much is this going to cost the federal government? That's actually the political debate that occurred in Arkansas to get it passed the first time. It was not about state spending. They just took that right to the bank.
Great. I wanted to invite our 2 Minnesota representatives for our panel. Commissioner Cindy Jessen, thank you so much for coming. We appreciate it. Representative Matt Dean. I think they're...
Oh, I've done that twice now.
Representative Dean, I want to start with you and kind of bring up what I think has been a pretty consistent theme in the comments by Deb Bachrach and Andy Allison and Brett Davis, which is that the focus on Medicaid is both about coverage issues, which populations and how, but it's also about a fundamental transformation of the delivery system and payment. Could you give us your perspective as someone who has been at this for almost 10 years and has been involved in past efforts at reform, at any similarities you see in what's being talked about either around the country as Deb's described or in Arkansas and Wisconsin?
Sure. Well, thanks, Larry, for having us today, and I really appreciate everybody taking time to come in today on a beautiful Minnesota summer day to talk about Medicaid reform policy and expansion, and I can't believe all of you are still here, so that's awesome. It's very hard for us, even with folks on the healthcare committee. Sometimes when you're presenting a bill, you look around and you're talking about healthcare bills, and our TLAs are 3-letter acronyms, and I look around and I see like 17 golden retrievers just kind of looking at me. So it's just great to see folks engaged about this very important topic, so thank you. And some things really do ring true, and we really are very, very interested in learning from other states. The states are the laboratories of democracy, and I think to the extent that Minnesota is allowed to experiment and to try different things, I think we're going to add to that because of our history and our heritage as a pioneer state for medicine, the delivery of medicine and discovery. I think we've got a lot to offer other states and a lot to learn from other states as well. We have in Minnesota, I'm a conservative Republican. So when I hear Deb talk about the practicality of it, my ears perk up and I get very excited because I'm very interested in how this thing is actually going to work and how we're going to deliver services. In Minnesota, I say that we should be leading national reform and not following it because we're really good at it. We're a little self-righteous in Minnesota. Our kids are above average and our women are strong and our men are good looking, but we actually do this very well. And we want to make sure that we maintain our quality. We've got very high quality, very low cost relative to just about any other state that we compare ourselves to. And so we don't want to step backwards. And that's what's very important to us as we move forward, that we not move backwards. So that when we can learn from other states, we want to be able to do that. And when we looked at Medicaid expansion in Minnesota, you say, well, how did that happen in Minnesota? In 2011, Governor Dayton initiated that. We said it was kind of a jump ball in 2010. We couldn't decide between the legislature and the governor whether or not we were going to expand. We said it was a jump ball. We'll let the incoming governor decide. The Republican governor said he wouldn't expand. The Democrat governor-elect, Mark Dayton, said he would in his first act as governor. He did, in fact, in 2011 expand coverage. So that's the trail that we've been going down ever since. And as conservatives, now in the minority in the legislature, we're saying We don't want to move backwards in Minnesota. We've had a program and have a program that takes care of folks with pre-existing conditions that very few other states have, called MSHA. We've got a program called Minnesota Care that's been in fact since 1994 that takes care of providing health care for people with low income. So that's been provided very good care for very many years that we're looking at moving back from as we expand Medicaid. And we had a program called General Assistance Medical Care for single adults without children to provide care for those folks. So we have 3 state programs that provide a lot of the care that the ACA wants to provide to the rest of the country. So we're saying, well, if we're already doing this stuff, leave us alone, or at least make sure that we're going to come out of this thing better than we're going into it. And so as we talk about implementing this in the past couple of years, we've seen a lot of folks who've lost coverage, either through their small business and small plans, as we're moving forward with the changes in the regulatory environment and costs increasing. So we're very mindful of that in that framework moving forward. And like I say, we want to and I was very excited to learn about Arkansas and Wisconsin and some different approaches that they're taking. I got in trouble a few years ago for making fun of the North Dakota Capitol. We were fixing up our Capitol and their Capitol. I don't know if you've ever seen it. It looks like an office building. And our speaker is from North Dakota, so I said, State Farm called and they want their office building back, in North Dakota as their capital. And I got in trouble, and the governor of North Dakota yelled at me, and I got in trouble for that. And I said, well, even if I did call State Farm, I wouldn't know who to apologize to, which got me into a little more trouble. But I can tell you, in my office, I have a Capitol rendering of ours. We've got a beautiful Capitol. We're fixing it up right now. And we had a competition that Cass Gilbert won. And the person who took second place was a guy named Thomas Mann. And you never see that because he finished second place. But he actually was commissioned for the Arkansas State Capitol, and he won that commission. And over a 9-year period, was in fact building that building. And it broke down through the politics of building a building, and somebody ran for governor against the building, basically. Thomas Mann was fired as the architect, and our architect, Cass Gilbert, came in and finished it and took credit for it. So I love competitions between the states. And,
better luck next time.
I think we can learn so much from each other and hopefully lead that discussion. Representative Dean, let me just follow up quickly. There's certainly at least a decent chance Republicans will regain the majority in the Minnesota House. And as I look at the numbers, I think it's more than a 50% chance. So what I've heard you say today, and I'm trying to listen carefully, is I'm not hearing the language of repeal. The language I'm hearing is moving forward. And it sounds to me as if what you're talking about are ways to improve the execution of what of the reforms that have been put in place, rather than kind of taking them down. Is that fair, or am I missing something?
Well, I think what we're going to be looking at is what works, and what works is competition. I think with the private market, we've seen with the implementation of the ACA and MNsure in Minnesota, we've seen the private market underperform within that. We've seen basically a shift from one public program to another, and our projections for the private market are about 80% off currently. So the costs are too high and the numbers are too few for our private market. So I'm here to say that we're very interested in other private sector approaches to that. And if you say repeal or not repeal, that will be up to the incoming legislature. And right now we've got 134 races to run across the state of Minnesota that have to come first. And I think I would put it at a bigger hill to climb than you would, perhaps, but I'm glad about your optimism in the Republicans in the Minnesota House.
Commissioner Justin, There's so many questions that have been raised today. But first, let's start off with what Representative Dean just said, which is that he would like to see an expansion of private market. I'm curious about that. I mean, obviously, when you look at MNsure, the sign-up has been much higher for the public plans than for the private commercial plans. But it also seems that when you kind of look through the reforms in Medicaid, and some other reforms have been done in Minnesota, that there seems to be an effort to look at competition, to look at some fairly significant transformations in how care is provided and how the providers are paid. Could you talk about that a little bit?
I'd be happy to. There's much that Representative Dean said that, I agree with, and I certainly think we're lucky to be in a state. There was just a state ranking, so it's not just what we believe, Representative, but there was a state ranking that came out this summer that said Minnesota has the best health care system in the country. Number one. So we, as far as where you start from, that's a great place to start. But I'll also be the first person to talk about that, we have a lot more to do. And I think that when the Affordable Care Act came into play, it was kind of like there's the access piece. Yes, we need to get more people into coverage, but there's also if we're going to bring, kind of just think from a national perspective, 34 million more people into health insurance, we have to do something to control costs, or it just becomes unsustainable. And I think from Minnesota's perspective on the access piece, the Medicaid expansion piece was really not a hard call. I think the politics at the national level had colored it. But we were covering those people in different programs, as you suggested. But we were already paying at one, before the Medicaid early expansion, 100% state dollars to cover these single adults. So this saved money for our state just from an economic basis and gave us better coverage options and, better for providers because we didn't have those hospital caps and things. Saved us a lot of money. But I think that we were just really conscious, as far as the reform efforts. Even before the Affordable Care Act came into place, we got to do something on the cost front. So we had Minnesota Care from over 20 years. We had the 2008 kind of bipartisan efforts. So we were implementing healthcare homes before that came along. We were doing payment reform before. But I think that really after, the Affordable Care Act, I think we really did even more and moved quickly. So good foundation with a lot of bipartisan support for that foundation, but some of the things we did really very much relied on competition. We, just from a Medicaid perspective, I think we very much, as, I think Scott in your comments and, Andy in yours, we wanted Medicaid to be kind of a driver, not just to be a smart purchaser, but also to, provide that leverage so that we could move the dial to bend the cost curve across Minnesota, not just in our Medicaid program. So one of the first things we did was put all of our managed care contracts, out for competitive bids. And we saved, over 3 years, total savings, managed care reforms, over $1 billion. But I think we moved beyond that to say, when we want to not only just get, capture savings, but continue to do this, and we just did another round last year, and start asking questions. So we're waiting, well, what are you doing for overall reform efforts? Because the two big things we have to do is we got to change the financial incentives, and we have to do more to integrate care so people aren't just moving from silo to silo. So we started weighting that too in our contracting. But I think even more significantly, we also started really doing what, I guess nationally they're called accountable care organizations. We were the first state to be authorized, the first state to do kind of these Medicaid ACOs in the country, where we're now contracting directly with providers, whether they're serving our clients in fee-for-service or managed care, and saying, look, here's the projected 3-year line for these enrollees, and if you come in lower and meet our quality standards, we'll share those savings with you. But you're going to take some risk too. And I think that's just some phenomenal examples, and we're already starting to see savings where that's driving, because it really is, once again, kind of changing those incentives, and but also kind of pushing people to more integrate. And but on the competition front too, I think MNsure has helped with that. I think that competition's why we have the lowest rates in the country. But I think there's more that we can do for competition. So as far as competition, as the person who kind of put all of our managed care contracts out to bid, I'm pro-competition. And I remember when we kind of stepped back and talked about lessons learned, one of our first lessons was competition works. But I think how we do that in Minnesota is different than how you do it in Arkansas, just because of, once again, as Brett was saying, where we started from. And we started from a place where we were doing Medicaid managed care, and we're already doing a lot of coverage and a lot on payment reform.
That's, we could be here for a couple hours.
Yeah.
I want to put that out there. I want to ask Brett Davis, help me think something through. And this is an honest thing that I struggle with. There are two views about government. One is that government displaces private markets and it undermines competition. I mean, we're both very familiar with, we're all familiar with that argument. The presentation that Commissioner Jessen just made seemed to argue that a certain type of government intervention that's targeted in particular ways to encourage integrated care, to encourage focus on costs and on quality, can actually improve and extend competition. So help me think that through.
I think in Wisconsin specifically, and it's a really good observation and a good point, I think it's a blend of both. Government's not going to go away. Every state's cutting their federal poverty level lines differently and paying slightly differently. But in Wisconsin, the approach we've taken, we're calling it a statewide value committee. So it's a public-private partnership that exists. We rallied around, I know Minnesota got a SIM grant, and Wisconsin's applying for one of the design grants to help accelerate some of the private initiatives that are going on to align payment reforms. So when I was Medicaid director, when I would pick up, the difference between being on the commercial side now in private health insurance and being in Medicaid is that when I call a hospital CFO, they actually answer my call now. They wouldn't always pick it up. I'd have to call a couple times, say, yeah, this is Brett, and explain myself a little bit more. It's Medicaid. But the power in it, what I did in Medicaid was I aligned myself with the employers. So there's a cooperative in Wisconsin called the Alliance, and it's a cooperative of self-funded employers. So I just took Medicaid and the concepts around it and wrapped around some of the initiatives that they were working on. And then I folded in the employee trust funds, ETF, in Wisconsin, so for government employees. And between Medicaid, ETF, and some of these employer groups, that alone captured probably 40% of the market share. So that's where the competition, and it depends what problem you're trying to solve and where you put your money for solving things, but I wanted to solve some of the service delivery reform issues to help keep costs down, become more efficient. So I felt like it was a blend of both that has to happen, and alignment of incentives is absolutely critical and key to making reforms to help keep costs down in the future.
At least in terms of words here, I'm hearing a lot of convergence and similarity. I mean, everyone here is for integrated delivery. This is a huge change. I mean, in Arkansas, you've got, I don't know, you would probably know the exact number, but I think of it as like Dr. Welby, Marcus Welby. Remember, the individual doctor? It's like so many separate, small practices. It's not just Marcus Welby, but 5, 6 or so folks. And what we're talking about are creating systems that integrate care. This has obviously been something that's been in Minnesota for a long time. And what I'm hearing from Commissioner Jessen is encouraging that, looking for ways to leverage that to drive lower costs and better quality has been, and improved health. There's I think, a really interesting experiment that's going on that has been supported by a federal grant for innovation in several spots in Minnesota that are asking counties to consolidate. Now, this is an idea that's not new, and I can almost see Representative Dean nodding, because I remember Governor Plenty talking about this for all 8 years. 87 counties, can we not consolidate in some way? And I'm not saying it's the same thing, but there is an effort to consolidate some counties or invite them to consolidate using this federal grant to focus on health and how to improve health. Is that fair?
Which one?
Either one.
Well, I think that some of the things that we're looking at are purchasing, how do we purchase healthcare, and the counties are purchasing it. Could they get together and have some quantity of scale in how they do that and how they deal with the state, and that we have seen some interesting proposals put forward by that. And also, I think moving forward that would certainly be a way that we could leverage some states where we have less competition, and particularly in rural Minnesota, we have less competition for small market plans than we do in the metro area. So that's something we're very interested in.
Commissioner Justin, do you want to weigh in?
I think especially for the Medicaid population in states like Wisconsin and Minnesota, where we have kind of delivery at the county level, county involvement is really critical. And one of the efforts we have is kind of our contract we have with Southern Prairie, which is an alliance of about 12 counties in southwestern Minnesota. And so they came together and kind of approached, and we have now one of what we call our IHP, Integrated Health Partnership. It's one of our Medicaid ACO arrangements with this group of 12 counties and the providers to basically provide health care to that Medicaid population with those same changed incentives, so that there are the potential for savings if they're able to improve health and save money. And it's a great arrangement, and I think they're trying to really take this much as, and also say, and can we also do this, and Blue Cross, as I understand, is a partner in some of this, for our commercial population as well, and this to me is a really exciting model. It's about those because for the most costly and largest need Medicaid clients that we have with those complex conditions, they're getting a lot of county services. So we need we talk about silo shifting. It's not just in healthcare silos. Is it a county social services problem or is it a healthcare problem? We got to bring those folks together where they're working together. Then we're going to have better services and bring down costs. And I think it's a grand experiment we're running in southwestern Minnesota, and I'm very excited about it. And I also say, I've talked to other county collaborations that are really thinking about doing some of the same things.
So I've been kind of filtering in questions that you all put forward, but I do have a stack here. So we've got less than 10 minutes. I wonder if we can do a lightning round to address some of these questions. Deb Bachrach, I think you said something about assets no longer being considered when qualifying for Medicaid. Can you just talk about why that's no longer happening?
Well, the easy answer is the ACA, the Affordable Care Act, prohibits it.
Here's lightning for you.
The second answer is extraordinarily few people with low incomes have meaningful measurable assets. It is a waste of money to measure it, and really, really hard.
Thank you.
Thank you.
But a difficult sell in the legislature.
Yes, so we've got three right answers here, but at the end of the day, the law trumps. So there you go.
So there are a series of questions here, basically data questions. All you data freaks out there, raise your hand. And the question is essentially about collecting and tracking medical outcomes and costs. And Annie Allison, one of the questions is directly to you. Do the medical outcome statistics exist that will allow you to verify the health outcome differential that you were predicting?
Yes and no. So Arkansas will collect of its own volition, and also because of the federal requirements as a condition of the waiver that we received and the money that we received through that waiver for the private option. We'll be collecting very detailed, primarily claims. I won't get into the other health data that we collect as a result of our payment reforms, but primarily claims. But you cannot prove the success of Arkansas's experiment relying solely on Arkansas's data, because there is no alternative within the state boundary. There is no control group within the state. So it will be dependent, and this is what I told the federal agencies, before the Affordable Care Act was implemented, and they were collecting, questions, how do you measure this? And I said, you collect the data because you're the only ones who will be able to prove whether it worked in Arkansas or didn't, or worked in Minnesota or didn't. You've got to use that interstate variation. Perfect natural experiment, given that states have done so many different things.
Brett Davis and Commissioner Jessen, another question which asks, I guess more positively, how are you using data on utilization and cost to drive reform?
One quick example. So I was talking about our IHPs, these Medicaid ACOs. We have 165,000 of our enrollees now that are, part of this. Every month, we give data on utilization and the cost to those providers so that they're able to see how those, because if they're responsible for those Medicaid enrollees, they need to know, are they using the emergency room? Are they not? What are they going? What are they doing? So we are giving them a lot of data every month. And we're also, through our SIM grant that you referred to, really trying to beef up the analytics so that that smaller providers too will have the ability to really analyze that data and use it to say, okay, who are our higher cost, higher risk enrollees, so that we know what interventions we need. So that is really, I think, part of what's driving the initial success of this program.
We're doing some similar things in Wisconsin, but I will say that data analytics, at least in Wisconsin, and I can't speak for other states, is probably our weakest point. And if you're good at data analytics, and if you're an organization that has good infrastructure to collect information and report cleanly, you are well ahead of the game. People who understand, it's not just, we're not living in a day and age right now that you can just get some data and just, too often in Wisconsin Medicaid, it was sitting on the shelf because people didn't have the skills to be able to look at it and interpret it and then start to actually offer up and be able to communicate solutions out of it. And so part of our effort was to build those human resources and align our resource infrastructure on data to be able to improve it. So we're doing some, but we have a long ways to go, in my opinion.
There was obviously, when managed care was introduced 3 decades ago, there was a backlash that developed over the next decade where many consumers said that they felt that the managed care organizations were cutting needed care in order to make a buck. And this became a bipartisan effort. We saw it in many states, healthcare bills of rights and that sort of thing. So one of the questions we have from the audience is, why do we think this time that affordable care organizations and integration will improve health of the Medicaid beneficiaries?
We don't.
Well, but
Let me just finish the point. Managed care doesn't do that. Managed care is the collection of a premium and the advance payment of predicted health costs. And, the independent contracting with providers and the independent networking that goes along with that, that's a business model. That doesn't change outcomes. It's what you do with it. And what you've heard is from everyone, I think up here, you've heard various state strategies for what you do through managed care contracts, what you do through the management of the independent individual marketplace, in Arkansas, how you coordinate those two things to use the leverage that government has, whether we like it or not, to come up with the commonality. VHS versus beta, for example, what kind of, device are you going to attach to your, is everyone going to build those are decisions that government sometimes does have to make. So it's not about managed care. It's about what you do with the purchasing.
I would say it slightly differently. And I think whether we're talking about managed care organizations, MCOs, or ACOs, or RCOs, the difference today is our ability to get data. Now, we've all said it's far from perfect, but for the first time, we can measure costs, and we have some ability to measure quality, outcomes, and consumer satisfaction. And what you're seeing in the ACO, RCO world is the opportunity to share savings that is not purely a numbers-driven exercise. It is informed by quality measures and consumer satisfaction. And whether or not those additional elements can turn us away from denying care to make money, which can happen in any setting, is still an open question. But I think that's the promise of the ACOs and the RCOs, and ultimately of MCOs as well. I don't think either one's the bad guy. I think it's our ability to align the incentives, measure the outcomes, and pay appropriately. And I think the verdict's out.
Commissioner Jessup.
And can I just add one thing, because mostly I agree with what you're saying, Deborah. But we have to do a better job, even when we're contracting with health plans, to engage providers and engage consumers as well. And for Medicaid, that's one of our huge challenges, right? Because while there's a role in many of these places for managed care, one of the lessons I think we've learned, and why I think these provider contracting arrangements we're doing is so important, if we don't really engage providers, we're not going to see the fundamental changes that we need. And if we don't, and we've got to, at least working through the providers, engage consumers too.
I agree.
We have run out of time. I want to acknowledge and thank Blue Cross Blue Shield and Scott Keefer for their support of this series. We're hoping to have another panel or two in this fall, picking up on some of the big issues, including the second open enrollment period. So there's a lot more to come. Pulling together these 5 people, no easy matter. Lee Chittenden is the master of the organizer, and thank you so much, Lee. You were just brilliant. I don't know how you did it. And this panel, huh? Come on now. You know, a lot of times you hear today about how nothing gets done in politics. Here are 5 people who are in the vortex of politics and policy, who come at it from different perspectives, but they care, and they're making a big difference. Thank you, Representative Dean, Commissioner Jessen, Brett Davis, Andy Allison, my good friend, Deborah Bachrach. Thank you for coming.